On a quiet evening in the autumn of 1920, in a modest rented room on a residential street in London, Ontario, a young surgeon sat alone at his desk. The lamp cast a small circle of warm light over a scattering of borrowed textbooks and a single medical journal, open to an article he had been reading for the better part of an hour. The house was still. Outside, the Canadian night had settled in early, as it does in late October, and the elms along the street had already surrendered most of their leaves. Frederick Grant Banting was 30 years old, and by almost any conventional measure, his life was not going particularly well. His private surgical practice had attracted so few patients that some weeks his earnings amounted to nothing. A relationship he had valued had recently come apart. To supplement his income, he had taken a part-time teaching position at Western University, demonstrating in subjects he had no particular expertise in. He was not a researcher. He had published nothing of significance. He possessed no laboratory, no academic reputation, and no connections in the world of medical science. And yet something in the article before him would not let him rest. The paper, written by the American pathologist Moses Barron, described a clinical observation about the pancreas, the soft organ tucked behind the stomach, responsible both for producing digestive enzymes and for some other, far less understood function. What caught Banting's attention was a detail about what happened when the pancreatic duct became blocked. The bulk of the organ withered away, but certain tiny clusters of cells, scattered through the tissue like islands in a sea, survived. These clusters had been identified in 1869 by a young German medical student named Paul Langerhans, who described them in his doctoral dissertation without knowing what they did. By 1920, the scientific world suspected that these islands held the key to one of the most devastating conditions known to medicine, one that was claiming the lives of thousands of children every year with a regularity no doctor could prevent. That condition was diabetes mellitus. The word itself derives from the Greek verb meaning to pass through. The physician Aretius of Cappadocia, writing in the 2nd century of the Common Era, described a mysterious affliction in which the body seemed to dissolve itself from within, patients consumed by unquenchable thirst, wasting away despite drinking enormous quantities of water. For centuries, physicians could observe this process but do nothing to halt it. By the 1700s, the English physician Matthew Dobson had confirmed that the sweetness detectable in patients' urine was due to sugar, and the fuller name, diabetes mellitus, from the Latin for honey, became standard. But naming the enemy did not mean understanding it. The 19th century brought a cascade of insights. Claude Bernard demonstrated that the liver played a central role in sugar regulation. Then came Langerhans and his mysterious islands. And in 1889, at the University of Strasbourg, Oskar Minkowski and Joseph von Mering performed the experiment that reshaped the field. They removed a dog's pancreas to study fat digestion and watched, astonished, as the animal developed severe diabetes within hours. The conclusion was inescapable. The pancreas produced some substance essential to sugar regulation, and without it, the disease appeared with terrifying speed. The logical next step seemed obvious. If such a substance existed, it could be extracted and given to patients. The race to isolate this hypothetical internal secretion began immediately and continued in frustration for more than 30 years. Georg Sulzer in Berlin produced extracts that showed promise but caused dangerous toxic reactions. E. L. Scott at the University of Chicago obtained suggestive results that his supervisor declined to support. Israel Kleiner at the Rockefeller Institute demonstrated that filtered pancreatic extracts could lower sugar levels in diabetic dogs, but his work was interrupted by the Great War and never resumed. In Bucharest, Nicolae Paulescu conducted careful experiments whose publication would come too late to claim priority. Each investigator came within reach of the answer and was turned away by impurity, toxicity, institutional indifference, or the fundamental biochemical problem that defeated them all. The pancreas produces extraordinarily powerful digestive enzymes, and those enzymes destroyed the fragile secretion during every attempt to extract it. The prize was being devoured by its own source. While scientists struggled, the human toll continued to mount, nowhere more visibly than in wards devoted to children. Juvenile diabetes struck suddenly, often in previously healthy children. Unlike the milder form that appeared gradually in older adults, it progressed with terrible swiftness. A child who had been running and playing might, within weeks, become consumed by thirst, lose weight rapidly, and begin to emanate a distinctive acetone-like odor, the scent of a body turning to its own reserves because it could no longer use sugar. Without intervention, the descent into diabetic coma followed within months. Rarely did a child survive beyond a year or two from the first symptoms. Into this landscape stepped Frederick Madison Allen, whose approach would become one of the most emotionally agonizing chapters in pediatric medicine. Allen had spent years studying diabetes at the Rockefeller Institute, and his conclusion was stark. Since the diabetic body could not metabolize sugar, the only way to extend life was to drastically reduce all food intake. His protocol called for as few as 400 or 500 calories per day, with regular fasting periods of near total abstinence. The results, in a narrow clinical sense, were real. Patients survived longer, but survival on the Allen diet tested the limits of what families and physicians could endure. Children were perpetually, achingly hungry. They lost weight until their frames became skeletal. Parents were instructed to lock away food. Nurses in the wards at the Hospital for Sick Children in Toronto, at Allen's Physiatric Institute in New Jersey, faced the daily torment of enforcing starvation upon children who pleaded for something to eat. Allen was not a cruel man. He saw no alternative. In a world without the missing secretion, his method was the only tool that worked at all, and he applied it with the rigor of a scientist who believed that discipline, however painful, was preferable to the only other option available. This was the world that Frederick Banting confronted on that October night, though he did not yet know its full dimensions. He was not a diabetes specialist. He had never treated a diabetic child. What he had was a single idea, clear, simple, and possibly naive, scribbled in a notebook at 2 in the morning in handwriting so hurried that some of the words were misspelled. The idea was this: if the digestive enzymes of the pancreas destroyed the internal secretion during extraction, then what if one first eliminated those enzymes by surgically tying off the pancreatic duct, waiting for the digestive tissue to wither, and only then extracting the secretion from the surviving islet cells? It was not entirely original. Elements existed in the literature, but no one had pursued it with the combination of surgical skill and single-minded determination that Banting was about to bring. He knew he could not do it alone. He needed a laboratory, animals, equipment, and the guidance of someone who understood the science far better than he did. There was one obvious place to turn: the University of Toronto, home to one of Canada's most distinguished physiology departments, led by a man whose expertise in carbohydrate metabolism was recognized around the world. That man was John James Rickard MacLeod, and convincing him would prove to be the first of many battles in a story about to unfold with a speed and intensity that none of its participants could yet imagine. To understand what Frederick Banting carried with him when he boarded a train from London to Toronto on the 8th of November 1920, one must understand the man himself, not as the monument he would later become, but as the restless, uncertain figure he was at that moment. He had been born in 1891 on a farm near the small town of Alliston, Ontario, the youngest of 5 children in a devout Methodist family. The landscape of his childhood was one of open fields, hard physical labor, and a quiet, stubborn self-reliance that would define him for the rest of his life. He was not a brilliant student. He was persistent. He entered the University of Toronto's medical program and proved himself a competent but unremarkable trainee, solid in the practical disciplines, less comfortable with the theoretical. He graduated in December of 1916, in the middle of the Great War, and almost immediately shipped overseas as a military surgeon with the Canadian Army Medical Corps. The war shaped him profoundly. He served at field dressing stations and casualty clearing posts in France and Belgium, working under conditions that no classroom could prepare a young doctor for. At the Battle of Cambrai in September of 1918, he was struck by shrapnel and sustained a serious wound to his right arm. The medical officers on the scene recommended evacuation, but Banting refused. He continued tending to others for hours before his own condition forced him to stop. For this, he was awarded the Military Cross. The incident revealed something essential about his character, a stubborn, almost reckless determination to push forward regardless of personal cost. It was the quality that would carry him through the summer of 1921. It was also, perhaps, the quality that would make the years after his triumph so difficult. He returned to Canada in 1919, restless and without direction. He attempted to establish a surgical practice in London, Ontario, choosing the city partly because a woman he hoped to marry lived nearby. The practice faltered. Patients were scarce. He spent long afternoons in an empty office, waiting for a knock at the door that rarely came. To fill his time, he accepted the part-time teaching post at Western University. And it was this appointment, more than any grand scientific ambition, that placed Moses Barron's article in his hands on that October evening and set the entire chain of events in motion. Now, carrying his idea like a fragile thing that might shatter if exposed to too much scrutiny, he arrived in Toronto and requested a meeting with Professor John James Rickard MacLeod. MacLeod was, in almost every respect, Banting's opposite. Born in 1876 near Perth, Scotland, he had trained at the University of Aberdeen and in Leipzig before establishing himself as one of the foremost authorities on carbohydrate metabolism in the English-speaking world. He had been recruited to the University of Toronto in 1918 to lead its Department of Physiology, and he brought with him a formidable reputation, dozens of publications, international connections, a precise and methodical scientific mind, and an authority that younger researchers rarely dared to challenge. He was courteous but exacting, politically astute within the academic world, and deeply skeptical of outsiders who arrived with grand ideas unsupported by rigorous evidence. Banting was precisely such an outsider. Their first meeting, which likely took place in MacLeod's office in the medical building on the university campus, was by most accounts an awkward affair. Banting was nervous. He was not a fluent speaker under the best of circumstances, and the prospect of presenting his half-formed hypothesis to one of the country's leading physiologists made him stumble over his own words. He outlined his idea about pancreatic duct ligation, tying off the duct, allowing the digestive tissue to degenerate, and then extracting the internal secretion from the remaining islet cells. He proposed to do this surgically, in dogs, using skills he had acquired as a military and general surgeon. MacLeod listened and responded with the caution of a scientist who had spent years studying the very problem Banting proposed to solve. He pointed out that the idea was not entirely new. Other researchers had explored related approaches. He questioned Banting's familiarity with the existing literature, which was, in truth, very limited. He raised methodological concerns. By Banting's later account, the meeting felt dismissive, even humiliating. By MacLeod's later account, it was simply a rigorous evaluation of a proposal that lacked scientific detail. And yet, MacLeod did not refuse. Something in Banting's persistence, or perhaps in the surgical angle of the proposal, which distinguished it from the purely biochemical approaches that had already failed, persuaded the professor to offer a cautious, limited form of support. After a second meeting, and possibly a third, MacLeod agreed to provide Banting with a small laboratory space in the medical building, a supply of 10 dogs for experimental use, and the assistance of a student who could perform the biochemical measurements that Banting himself was not trained to do. There was a condition, spoken or implied. MacLeod would oversee the work intellectually, but the day-to-day labor would be Banting's responsibility. And there was a practical reality. MacLeod planned to leave Toronto in late May for his annual summer visit to Scotland. Banting would be largely on his own. The arrangement was minimal. It was not a major research grant. It was not an endorsement. It was, at best, an opportunity offered with low expectations. A senior scientist allowing a determined stranger to test an unlikely idea in a borrowed room during the quiet months when the university was half empty. The student assigned to assist Banting would prove to be as consequential a choice as any in this story. MacLeod selected two candidates from his physiology program, Charles Herbert Best and Clark Noble, both capable young men completing their studies. They would alternate, each taking a shift working with Banting over the summer. A coin was tossed to determine who would begin first. Best won. Charles Best was 21 years old, tall, athletic, and possessed of a quiet competence that belied his youth. He had recently learned a technique for measuring sugar concentration in small samples, a method developed by the biochemists Otto Fallen and H. Sean Wu, and this skill would be indispensable for evaluating whether the pancreatic extracts had any effect. Best was earnest, hardworking, and eager to participate in real research. He arrived for what he expected to be a temporary assignment, a few weeks in a summer laboratory before handing the work over to Noble. He never handed it over. Whether by design or by the momentum of events, Noble never took his turn. Best remained at Banting's side through the entire summer and into the autumn, becoming not merely an assistant but a full partner in the work. The coin toss that placed him in that laboratory became one of the most quietly momentous small events in the history of science. A fraction of a second that determined whose name would be linked to the discovery and whose would be largely forgotten. The two men began their work in mid-May of 1921 in a small room on an upper floor of the medical building. The space was not designed for the kind of research they were about to undertake. It was hot. Toronto summers could be stifling and poorly ventilated. The equipment was basic. There was no dedicated support staff, no team of technicians, no institutional infrastructure surrounding them. They were, in effect, two men alone with an idea, a set of surgical instruments, and 10 dogs whose fates would determine whether decades of scientific failure could finally be overcome. Banting brought his surgical training. Best brought his biochemical technique. Neither had significant research experience. Neither had published a scientific paper. Neither fully understood the theoretical complexities of the problem they were attacking. The intricate interplay of enzymes, hormones, and metabolic pathways that more experienced scientists had spent careers investigating without resolution. What they had instead was something harder to quantify, a combination of naivety and nerve that allowed them to attempt what more knowledgeable researchers might have considered futile. Banting, in particular, possessed a tunnel vision that bordered on obsession. He had staked everything on this idea, his time, his dwindling savings, the last remnants of his professional credibility. He had no fallback position, no alternative career plan, no safety net. If the experiments failed, he would return to his empty practice in London with nothing to show for the summer, but a set of skills no one was asking for. MacLeod, before departing for Scotland, left detailed instructions for the experimental protocol. He specified the procedures for duct ligation, the timeline for allowing the pancreatic tissue to degenerate, the controls that would need to be maintained, and the measurements that Best should perform at each stage. These instructions would later become a point of fierce contention. Banting would insist that MacLeod's guidance was minimal and that the real work was done without supervision, while MacLeod's supporters would argue that his intellectual framework was essential to the project's design. The truth, as is often the case in such disputes, likely fell somewhere between these positions. In any event, by late May MacLeod was aboard a ship bound for Scotland, and Banting and Best were alone in Toronto with their laboratory, their dogs, and the weight of an idea that was about to be tested against reality. The medical building grew quiet around them as the semester ended and students departed. The corridors emptied. The summer light stretched long through the windows. And in that small, overheated room, the most consequential experiment in the modern history of a disease that had tormented humanity for 2,000 years was about to begin, conducted not by the leading scientists of the age, but by a struggling surgeon and an undergraduate who had won a coin toss. The medical building at the University of Toronto stood largely deserted through the early weeks of June 1921, its corridors emptied by the end of term, its lecture halls silent. On an upper floor, in a small room that served as both operating space and laboratory, Frederick Banting and Charles Best began the work that would consume their summer. The heat arrived early that year and settled into the building with a persistence that made the cramped quarters feel even smaller. There was no air conditioning. The windows, when opened, offered little relief. The smell of ether and antiseptic hung in the still air alongside the warmth, and the two men, one a 30-year-old surgeon with no research credentials, the other a 21-year-old student who had barely finished his coursework, set about their task with a determination that compensated, at least partially, for what they lacked in experience. The experimental plan, shaped by Banting's original idea and refined by MacLeod's instructions before his departure, followed a clear logic. The first step was surgical. Banting would ligate the pancreatic ducts of several dogs, tying them off so that the digestive portion of the organ would slowly atrophy over the following weeks. While waiting for that degeneration to occur, he would perform a second set of operations, complete removal of the pancreas from other dogs, rendering them diabetic. Then, once the ligated pancreases had sufficiently withered, the plan called for extracting material from the remaining islet tissue and injecting it into the diabetic animals to see whether their dangerously elevated sugar levels would fall. It was a straightforward concept. Its execution was anything but. Banting was a competent surgeon, but operating on dogs under these conditions bore little resemblance to working in a proper surgical theater. The animals required anesthesia, which had to be carefully administered and monitored. Postoperative care was demanding and constant, infections were a persistent threat, and the two men had no assistants, no veterinary support, no one to share the overnight vigils when an animal's condition deteriorated. They fed the dogs, cleaned their enclosures, administered medications, tracked symptoms, and recorded observations themselves, moving between the roles of surgeon, nurse, laboratory technician, and caretaker with an improvised efficiency born of necessity rather than training. The early weeks were marked by frustration. Several of the duct-ligated animals did not survive the procedures or developed complications that rendered them useless for the experiment. Banting, who was not indifferent to the suffering involved, found the losses demoralizing. He and Best worked through the setbacks with a grim persistence, repeating surgeries, adjusting techniques, learning from each failure. The process was slow, physically exhausting, and emotionally draining. There were days when the entire project seemed to teeter on the edge of futility. Two inexperienced researchers in an empty building, losing animals and running low on supplies, pursuing an idea that the broader scientific community had largely dismissed as a dead end. Best, for his part, proved to be far more than a passive assistant. His mastery of the Fallen Wu method for measuring sugar concentrations was essential. Without accurate, reliable measurements, the experiments would produce nothing but ambiguity. He performed the analyses meticulously, drawing small samples, running the chemical reactions, recording the numbers that would eventually tell the story. He also brought a steadiness of temperament that complemented Banting's more volatile personality. Where Banting was prone to impatience and dark moods, Best was methodical and even-keeled, anchoring the partnership during its most difficult stretches. By late July, after weeks of painstaking preparation, the first genuine test was at hand. A dog whose pancreas had been entirely removed, designated in the laboratory records by a clinical number rather than a name, had developed the full constellation of diabetic symptoms: soaring sugar levels, excessive thirst, rapid weight loss. It was fatting visibly, approaching the terminal phase of the disease. Banting and Best prepared an extract from the degenerated, duct-ligated pancreas of another animal, grinding the tissue, mixing it with saline solution, filtering it through a crude process that removed the larger impurities, and drawing the resulting liquid into a syringe. The injection was administered, and then they waited, measuring the sugar levels at intervals, watching the numbers, hopping for a signal amid the noise. The signal came. The sugar concentration in the diabetic animal system dropped, not dramatically at first, but unmistakably. Over the following hours, the decline continued. It was temporary. As the injected extract was metabolized and depleted, the levels began to climb again. But the pattern was clear. Something in that pancreatic extract was capable of lowering pathologically elevated sugar levels in a diabetic animal. They repeated the injections. The effect held. They tried the procedure on other diabetic dogs, and the results were consistent, imperfect, variable in magnitude but consistent in direction. Every time the extract was administered, sugar levels fell. Every time it wore off, they rose. Banting and Best called their extract islatin, after the islets of Langerhans from which they believed it derived. They did not yet fully understand what they had isolated, and the extract was crude, far too impure for any consideration of human use. But the principle had been demonstrated. After more than 30 years of failed attempts by researchers across Europe and North America, two men with almost no research experience had produced evidence that the internal secretion of the pancreas could be extracted, and that it worked. The elation was real but tempered. Banting understood, even through his excitement, that a crude extract tested on a handful of dogs in a makeshift laboratory was a long distance from a proven treatment. The results needed to be confirmed, refined, and subjected to the kind of rigorous scrutiny that the scientific community would demand before taking them seriously. And that scrutiny was about to arrive in person. MacLeod returned from Scotland in late September of 1921, rested, tanned from the Scottish Highlands, and prepared to evaluate what his unlikely protege had accomplished. The meeting between the two men, or more precisely, the series of meetings that followed MacLeod's return, would become one of the most disputed episodes in the entire history of the discovery, remembered differently by each participant and reconstructed differently by each subsequent generation of historians. What is not disputed is that MacLeod reviewed the data carefully and found both promise and problems. The results were encouraging. The sugar-lowering effect was real and reproducible, but the methodology, in MacLeod's assessment, fell short of the standards required for publication in a reputable scientific journal. The controls were inadequate. The number of animals was too small. The documentation was incomplete in places. The extraction process was inconsistent. These were, from the perspective of an experienced researcher, legitimate scientific criticisms, the kind of feedback that any rigorous supervisor would provide to a junior investigator presenting preliminary findings. Banting did not receive them that way. To Banting, who had spent the most grueling summer of his life in a sweltering laboratory, sacrificing his income, his practice, and his physical health for this work, MacLeod's cautious response felt like something far worse than scientific criticism. It felt like condescension. It felt like an attempt to diminish what he and Best had achieved. And beneath that perception lay a deeper, more corrosive suspicion, one that would poison the relationship between the two men irreparably. Banting began to believe that MacLeod intended to claim credit for the discovery, to insert himself into a narrative that belonged rightfully to the men who had done the actual work, while the professor enjoyed his summer abroad. Whether this suspicion was justified remains a matter of historical debate. MacLeod's defenders have argued persuasively that his contributions were substantial and essential. He had conceived the experimental framework. He had provided the resources. His deep knowledge of carbohydrate metabolism gave intellectual context to results that Banting, by his own admission, was not fully equipped to interpret. And upon his return, MacLeod did not merely criticize. He acted decisively to strengthen and expand the project. He assigned additional laboratory space. He directed Banting and Best to repeat their experiments with better controls. He suggested a crucial methodological improvement. Rather than relying solely on duct-ligated pancreases, which took weeks to prepare and yielded small quantities, they could try using whole pancreases from fetal calves obtained from local slaughterhouses. Fetal pancreatic tissue, MacLeod reasoned, had not yet developed the full complement of destructive digestive enzymes, and therefore might yield the internal secretion without the elaborate ligation procedure. This insight proved correct and would dramatically accelerate the production of usable extract. Most significantly, MacLeod brought in a fourth figure, someone whose technical skills would prove to be the essential bridge between a laboratory curiosity and a treatment that could be administered to human beings. His name was James Bertram Collip, a biochemist from the University of Alberta who happened to be spending his sabbatical year in Toronto. Collip was quiet, meticulous, and possessed of an expertise in protein chemistry and purification techniques that neither Banting nor Best could match. MacLeod assigned him a specific and critical task: take the crude extract that Banting and Best had produced and purify it. Remove the contaminants, the proteins, the cellular debris, the unknown substances that made it too toxic for human injection. Make it safe. Collip accepted the assignment and threw himself into the work with an intensity that matched Banting's own. But his arrival also introduced a new source of tension into an already fraught dynamic. The project that had begun as Banting's solitary vision, pursued with Best as his loyal partner, was now expanding beyond their control. MacLeod was directing the scientific strategy. Collip was performing the biochemical refinement. The center of gravity was shifting from surgical improvisation toward institutional science, and Banting, proud, insecure, and deeply possessive of what he considered his discovery, watched the shift with growing alarm. The autumn of 1921 became a period of accelerating progress shadowed by deepening personal conflict. The extract improved. The results grew more convincing. The fetal calf pancreas method worked as MacLeod had predicted. Collip's purification efforts showed early promise. The scientific case was building towards something that might, with sufficient refinement, be ready for the most consequential test of all, an attempt to treat a human patient. But within the walls of the laboratory, the four men who were collectively assembling one of the most important medical advances of the 20th century were already dividing into factions. Banting and Best on one side, MacLeod and Collip on the other, trust eroding, credit contested, personal resentments hardening into permanent grievances. The discovery was taking shape, but so was the conflict that would eventually overshadow it, a conflict not about science, but about the most human of questions: who deserves to be remembered and who gets to decide. James Bertram Collip arrived at the University of Toronto in the late autumn of 1921 carrying credentials that neither Banting nor Best could claim. He was 31 years old, already an associate professor of biochemistry at the University of Alberta, and he had come to Toronto on a Rockefeller Traveling Fellowship, a prestigious sabbatical that allowed him to spend a year working in a major research center. He was quiet by nature, precise in his methods, and deeply skilled in the art of extracting and purifying biological substances from animal tissue. Where Banting was a surgeon who thought with his hands and trusted his instincts, Collip was a bench scientist who thought in terms of molecular weights, precipitation curves, and solubility gradients. He was, in temperament and training, exactly the person the project needed at this critical juncture, and exactly the kind of person most likely to provoke Banting's insecurity. MacLeod's instructions to Collip were clear. Take the crude pancreatic extract that Banting and Best had shown to be biologically active and develop a purification process that would make it safe for human administration. The raw extract, while effective in lowering sugar levels in diabetic dogs, was a murky, impure solution filled with proteins, cellular fragments, and unknown contaminants that caused fever, pain at the injection site, and potentially dangerous reactions. No responsible physician could inject it into a human patient in its current form. The gap between a promising animal experiment and a viable clinical treatment was not a gap of principle. It was a gap of chemistry, and bridging it was Collip's task. He worked with an intensity that those around him found remarkable. His method involved fractional precipitation using varying concentrations of alcohol, a technique that exploited the fact that different proteins fall out of solution at different alcohol concentrations. By carefully adjusting the ratio, Collip could separate the active substance from the inert and harmful components that surrounded it. It was painstaking, repetitive work, requiring dozens of iterations, each one slightly modified, each one tested for both potency and purity. He worked late into the evenings, often alone in his section of the laboratory, running extraction after extraction, measuring, discarding, beginning again. While Collip refined the chemistry, the tensions within the team continued to deepen. Banting watched the biochemist's progress with a mixture of gratitude and suspicion. He recognized that Collip's skills were essential. Without purification, the extract would remain a laboratory curiosity, effective in dogs but useless for the patients who desperately needed it. At the same time, Banting feared that Collip's growing centrality to the project threatened to displace him and Best from the narrative of their own discovery. The extract had been their idea, their summer of labor, their achievement. Now a newcomer was performing the work that would make it clinically relevant, and MacLeod, who had been absent during the crucial months, was directing the overall strategy. Banting confided to friends that he felt the discovery slipping away from him, being absorbed into the institutional machinery of the university, where men with better credentials and smoother manners would inevitably receive the recognition. This anxiety reached a breaking point sometime in the winter months. The precise details are disputed, and the accounts that survive are colored by the loyalties and resentments of those who told them. But according to Banting's own later recollection, there came a moment when he believed Collip was preparing to leave the project and pursue the purification work independently, potentially publishing results under his own name before Banting and Best could establish their priority. Whether Collip genuinely intended this, or whether Banting misread a conversation through the lens of his own insecurity, remains unclear. What several sources agree upon is that a confrontation occurred, physical in nature, brief but intense, in which Banting seized Collip and made clear, in terms that left no room for ambiguity, that the extract and everything connected to it belonged to the team as a whole, and that no one would publish separately. Best was reportedly present and intervened. The incident passed, but the damage to the working relationship was permanent. It is worth pausing here to recognize how extraordinary the situation was. Four men, a surgeon, a student, a professor, and a biochemist, were collectively developing a treatment that had the potential to transform the lives of millions. The scientific stakes could hardly have been higher, and yet the human dynamics of the collaboration were disintegrating under the pressure of ego, insecurity, and the fierce possessiveness that the prospect of a great discovery seems almost inevitably to provoke. Each man believed his contribution was essential. Each was correct, and none could find a way to hold that belief without diminishing the contributions of the others. Despite the interpersonal turmoil, the work moved forward. By early January of 1922, the clinical team at Toronto General Hospital had identified a patient for the first human trial. His name was Leonard Thompson. He was 14 years old. He had been diagnosed with diabetes at the age of 12, and for 2 years he had been maintained on a version of Frederick Allen's starvation protocol, a severely restricted diet designed to postpone the inevitable. By the time he was admitted to the hospital in December of 1921, the diet had done all it could. He weighed approximately 65 pounds. He was frail, listless, and fatting. The acetone odor on his breath was detectable from across the room. His father, who had watched his son diminish month by month, gave his consent for the experimental treatment. There was, in practical terms, nothing to lose. On the 11th of January, 1922, Leonard Thompson received an injection of pancreatic extract. This was not Collip's purified preparation. Collip had not yet completed his refinement process. The extract used was a version prepared by Banting and Best themselves, improved somewhat from the crude material of the previous summer, but still far from pure. The results were discouraging. The boy's sugar levels declined modestly, a drop of approximately 25%, but the improvement was insufficient to be considered clinically meaningful. Worse, the injection site developed a painful, inflamed abscess, an unmistakable sign that the extract contained irritating impurities. The attending physician, Dr. Walter Campbell, halted the injections. The trial, such as it was, had produced a result that fell somewhere between ambiguity and failure. For Banting, this was a devastating moment, months of work, an entire summer of sacrifice, and the first human test had yielded little more than a sore arm and a marginal change in chemistry. The boy was no better. The skeptics who had questioned the project from the beginning seemed vindicated. The distance between a laboratory effect in dogs and a meaningful treatment for a human patient had proved to be wider than anyone hoped. What followed was a period of 12 days that would determine the entire trajectory of the discovery. Collip, aware of the failure and its implications, redoubled his purification efforts. Working through the second and third weeks of January with an urgency bordering on obsession, he refined his alcohol precipitation technique, adjusting concentrations, temperatures, and processing times with the methodical patience that was his greatest scientific gift. He tested each batch on diabetic animals, measuring both its potency and its toxicity, discarding preparations that were too weak or too impure, narrowing in on the precise conditions that would yield an extract strong enough to work and clean enough not to harm. By the 22nd of January, he had produced a preparation that met his standards, significantly purer than anything the team had previously created. The next day, the 23rd of January, 1922, Leonard Thompson received a second injection. This time, the extract was Collip's. The effect was transformative. The boy's sugar levels fell sharply, not by 25%, but toward ranges that approached the normal. The ketone bodies that had been flooding his urine, the chemical signature of a body consuming itself, diminished dramatically and within days virtually disappeared. The abscess and inflammation that had marred the first attempt did not recur. Thompson's energy improved. His appetite returned. His father, who had prepared himself for the worst, watched his son begin, tentatively, to recover. The injections were repeated over the following days and weeks, and the pattern held. Each administration of Collip's purified extract produced a measurable, reproducible, and clinically significant improvement. Leonard Thompson was not cured. When the injections were withheld, his condition deteriorated again, confirming that the treatment addressed the symptoms rather than the underlying cause. But for the first time in the recorded history of the disease, a human being with severe juvenile diabetes had been pulled back from the edge by a pharmaceutical intervention. The news traveled through the hospital, then through the university, then outward into the broader medical community with a speed that reflected the enormity of what had occurred. Physicians who had spent their careers watching diabetic children fade away now confronted the possibility that the long, fruitless decades of searching were over. Letters began to arrive at the university, from doctors, from families, from desperate parents who had heard rumors of a breakthrough in Toronto and who begged for access to the new treatment for their own children. But at the very moment of triumph, a new crisis emerged, one that threatened to undo everything Collip had achieved. In the weeks following the Thompson success, as demand for the extract surged and the team attempted to produce larger quantities, Collip discovered that he could no longer reproduce his purification process. Something had gone wrong, a variable he had failed to record, a step he had performed intuitively without noting the precise conditions, a subtle change in the raw materials. Batch after batch failed to meet the standard of the preparation that had saved Leonard Thompson. The active substance was there, but the purity was not. For several agonizing weeks, the team found itself in possession of a proven treatment that it could not reliably manufacture. The crisis was eventually resolved. Collip, working backward through his notes and repeating his experiments systematically, recovered the method and stabilized the production process. But the episode exposed a vulnerability that would haunt the project until industrial partners with greater resources could be brought in. The extract was potent, fragile, and temperamental, a substance whose preparation depended on craftsmanship as much as chemistry, and whose reproducibility could not yet be guaranteed. For Leonard Thompson, the breakthrough held. He continued to receive injections and continued to improve. He would leave the hospital, return to something resembling a normal life for a boy of 14, and go on to live for another 13 years, sustained by the substance that had been tested on him during those January days. His case was not a fairy tale. The long-term consequences of the disease would eventually claim him. But the years he gained, years of consciousness, of experience of life beyond the walls of a hospital ward, were years that no physician in the history of medicine had previously been able to offer a patient in his condition. The question now was no longer whether the internal secretion of the pancreas could save lives. It could. The question was whether it could be produced in sufficient quantities, with sufficient consistency, to reach the thousands of patients who were running out of time. And the answer to that question would require resources, infrastructure, and industrial capacity far beyond anything a university laboratory could provide. The spring of 1922 brought a strange new sensation to the diabetes ward at Toronto General Hospital, something that the physicians and nurses who worked there had almost forgotten was possible: hope. For years, these wards had been places of quiet resignation, where the best that medicine could offer was a prolongation of suffering rather than a restoration of health. Now, one by one, patients began to receive the purified pancreatic extract, and one by one, they responded. Sugar levels fell, ketones receded. Children who had been too weak to sit up began to eat to gain weight to ask when they could go home. Dr. Walter Campbell, the clinician overseeing the trials, documented each case with the careful precision of a man who understood that he was recording something unprecedented. The extract was still produced in small batches, still variable in potency, still dependent on Collip's painstaking laboratory technique. But it worked. Case after case confirmed what Leonard Thompson's recovery had suggested. The internal secretion of the pancreas, properly purified, could reverse the immediate devastation of diabetes in human patients. Among the early recipients was a young man named Joe Gilchrist, himself a physician and a diabetic who had been managing his condition through rigid dietary restriction. Gilchrist volunteered to receive the extract and became not only a patient but an informal collaborator, reporting his own symptoms and responses with clinical detachment. His case provided a useful perspective from the other side of the needle, a trained medical mind observing, from within, the effects of a substance that science had been chasing for 3 decades. But it was another patient, arriving later that summer, whose story would come to embody the emotional power of the discovery more vividly than any clinical chart or laboratory record. Elizabeth Hughes was the daughter of Charles Evans Hughes, one of the most prominent men in the United States, a former governor of New York, a former Supreme Court justice, and at that time the sitting Secretary of State. Elizabeth had been diagnosed with diabetes at the age of 11 in 1919, and her mother had immediately sought the best care available, which meant Frederick Allen and his starvation protocol. For 3 years, Elizabeth survived on Allen's regime. She was intelligent, spirited, and determined to live, but the diet reduced her to a condition that was difficult to witness. By the time she arrived in Toronto in August of 1922, she was 15 years old and weighed approximately 45 pounds. She was too weak to walk unassisted. Her body had consumed nearly all of its reserves. She was, by any honest medical assessment, approaching the end of what Allen's method could sustain. Banting took her case personally. He administered the extract himself, adjusting doses, monitoring her response, watching for the signs of recovery that he had now seen in other patients, but that never ceased to astonish him. Elizabeth responded with a speed that startled even the physicians who had grown accustomed to the extract's effects. Within weeks, she was eating regular meals for the first time in years. She gained weight. Her energy returned. By the autumn, she was walking, laughing, writing letters home to her mother, describing her improving condition, with the breathless enthusiasm of a teenager rediscovering ordinary life. Elizabeth Hughes would go on to live for another 58 years. She married, raised 3 children, and lived a full, private existence in which she steadfastly refused to discuss her childhood illness or her connection to the insulin story. She requested that her medical records from the Toronto period be destroyed, and for decades her identity as one of the earliest and most dramatic cases remained largely unknown to the public. She passed from the world in 1981 at the age of 73, having outlived every member of the team that saved her. Her silence was a complex act, part desire for privacy, part insistence on being defined by something other than a disease, and perhaps part reluctance to revisit a chapter of her life in which she had come so terrifyingly close to the edge. Her case also illuminated an uncomfortable truth about the early months of insulin's existence. Elizabeth Hughes reached Toronto because her father was one of the most powerful men in the American government. His connections, his resources, and his ability to communicate directly with the University of Toronto's leadership secured his daughter a place in a treatment program that was, at that moment, available to almost no one. For every Elizabeth Hughes, there were hundreds of families without such access, parents who had heard rumors of the miracle in Toronto, who wrote desperate letters to Banting, to MacLeod, to the university, begging for a supply of the extract for their own children, and who received, in most cases, regretful replies explaining that production was still too limited to meet the demand. This was the central crisis of the spring and summer of 1922. The treatment existed, it was proven, it was transformative, and it could not be produced in anything close to sufficient quantities. Collip's laboratory purification method, refined as it was, remained an artisanal process, dependent on his personal expertise, limited by the equipment available in a university setting, and incapable of scaling to meet the needs of thousands of patients across a continent. Each batch required fresh pancreatic tissue from slaughterhouses, careful processing through multiple stages of alcohol precipitation, and extensive testing before it could be deemed safe for injection. The yield was small, the consistency was imperfect, and every day that production remained limited, children in hospitals across North America continued to fade on starvation diets, their families knowing that a treatment existed but unable to obtain it. The university administration and MacLeod both recognized that the problem could not be solved within the walls of an academic institution. What was needed was an industrial partner, a pharmaceutical manufacturer with the facilities, the chemical expertise, and the production capacity to transform a laboratory preparation into a standardized, mass-produced medicine. The search for such a partner led to Indianapolis, Indiana, and to a family-owned company that had been manufacturing pharmaceuticals since the 1870s. Eli Lilly and Company was not the largest drug manufacturer in the United States, but it was among the most respected. Founded by Colonel Eli Lilly, a Civil War veteran and pharmaceutical chemist, the firm had built its reputation on quality control and scientific rigor at a time when much of the American drug industry was still a murky frontier of patent medicines and unregulated concoctions. By the early 1920s, the company was led by Eli Lilly's grandson, also named Eli, and by a research director named George Henry Alexander Clowes, a British-born biochemist who had been following the Toronto developments with keen interest. Clowes had attended scientific meetings where MacLeod presented the team's findings, and he approached the university with a proposal for collaboration. The negotiations, conducted primarily between the university's Connaught Antitoxin Laboratories and the Lilly Company, resulted in an agreement finalized in late May of 1922. Eli Lilly would receive access to the extraction and purification methods developed in Toronto and would commit its industrial resources to scaling up production. In return, the company would supply the university with finished product for clinical use and would hold a limited exclusive license for manufacture in the United States during an initial period, after which the methods would be made widely available. The arrangement proved transformative. Lilly assigned a team of chemists to the problem, and among them was a researcher named George Walden, whose contribution would prove as consequential in its own domain as Collips had been in the laboratory. Walden developed a method of purification based on isoelectric precipitation, a technique that exploited the fact that the active substance in the extract had a specific acidity level at which it became least soluble and could be separated from impurities with much greater efficiency than the alcohol-based methods allowed. His process was more consistent, more scalable, and produced a purer product. By the late months of 1922, the Lilly factory in Indianapolis was producing insulin, the name that had by now been settled upon, over Banting's preference for Ilotin, in quantities that dwarfed anything the Toronto laboratory could achieve. The choice of name itself carried a residue of the ongoing conflict. Banting had coined the term Ilotin, and he preferred it. MacLeod favored insulin, derived from the Latin word insula, meaning island, a reference to the islets of Langerhans. The name insulin had also been proposed independently by other researchers in earlier years, and it had a cleaner etymological pedigree. MacLeod's preference prevailed, and the substance entered the medical vocabulary under the name it carries to this day. For Banting, even this small linguistic defeat felt like another act of appropriation, another instance of the establishment overriding the choices of the man who had started it all. But whatever bitterness lingered over names, the reality of industrial production was undeniable. Insulin began reaching hospitals across North America in the autumn and winter of 1922. Physicians who had spent their careers presiding over the slow diminishment of their diabetic patients now witnessed what many of them described, in letters and clinical reports, as something close to a resurrection. Frederick Allen's clinic in Morristown, New Jersey, the institution most closely associated with the starvation diet, was among the first to receive supplies, and Allen himself, whatever complex emotions he may have experienced watching his entire therapeutic philosophy rendered obsolete, administered the injections and watched his patients recover. Entire wards were transformed within weeks. Children who had been silent, listless, reduced to skeletal frames by years of caloric deprivation, began to eat, to move, to speak with animation, to resemble the children they had been before the disease claimed them. The demand, inevitably, outstripped even Lilly's expanding production capacity. The company worked to increase output, improve consistency, and reduce costs, while the University of Toronto moved to make the manufacturing methods available to other producers around the world. Within a year, insulin was being manufactured in England, Denmark, and several other countries, and the global supply, while still insufficient, was growing rapidly. In the midst of this expansion, the question of patents arose, And the answer the team provided became one of the most celebrated acts of conscience in the history of pharmaceutical science. Banting had initially resisted the idea of patenting insulin at all. His instinct, shaped by the values of his rural Ontario upbringing, his Methodist sense of duty, and his experience as a military surgeon who had served without thought of personal gain, was that a life-saving medical discovery should not be the property of any individual. It should belong to everyone. But colleagues and advisors persuaded him that a patent was, paradoxically, the best way to protect that principle. Without a patent, any manufacturer could produce insulin, including unscrupulous ones who might cut corners, produce dangerous imitations, and exploit desperate patients for profit. A patent held by the university would allow quality control and prevent exploitation, while ensuring that the substance itself remained widely accessible. On the 25th of April, 1923, Banting, Best, and Collip assigned their patent for the manufacture of insulin to the Board of Governors of the University of Toronto. The price was $1 each. Banting was reported to have expressed the conviction that the discovery belonged not to him, nor to any individual, but to the world, and that profiting from a substance that stood between a child and an early grave was something he could not reconcile with his conscience. The $1 patent became an emblem, a symbol of an era in which the relationship between medical science and commercial interest operated under assumptions that would, in later decades, come to seem almost unrecognizably idealistic. Whether those assumptions were naive or noble, whether they reflected a genuine ethic, or simply the economic realities of a time before the modern pharmaceutical industry fully took shape, would be debated for generations. But in the spring of 1923, as insulin flowed outward from Toronto and Indianapolis into hospitals around the world, the gesture carried an unmistakable moral clarity. The discovery had been made, the treatment was proven, the means of production were secured, and now, with terrible inevitability, came the question that great discoveries always provoke and that collaborative achievements almost never survive intact. The question of who, among these four imperfect, brilliant, quarrelsome men, deserved the credit. The Nobel Prize in Physiology or Medicine for 1923 was announced in October of that year, barely 18 months after Leonard Thompson had received his second, life-altering injection in a Toronto hospital ward. The speed was remarkable. The Nobel Committee, ordinarily deliberate and cautious in its selections, sometimes allowing years or even decades to pass before recognizing a discovery, moved with unusual haste, a reflection, perhaps, of the sheer visibility of the achievement and the global wave of attention that had followed insulin's introduction. Newspapers around the world had carried the story. Families who had watched children waste away on starvation diets were suddenly writing to Toronto, to Indianapolis, to their own physicians, asking for the new treatment. The transformation was so dramatic, so public, and so emotionally overwhelming that the committee evidently felt little need for the customary period of cautious evaluation. The discovery spoke for itself. The laureates named were Frederick Grant Banting and John James Rickard MacLeod. The reaction in Toronto was immediate and volcanic. Banting learned of the award and was consumed not by joy, but by a fury so intense that those closest to him feared he might refuse the prize altogether. His rage was directed not at the Nobel Committee in the abstract, but at a specific and, to him, intolerable fact. The prize had been shared with MacLeod, not with Best. The man who had stood beside Banting through the suffocating heat of that summer laboratory, who had performed the biochemical measurements that gave the experiments their evidentiary weight, who had worked without pay and without recognition while MacLeod vacationed in Scotland. That man had been passed over. In his place, the committee had chosen the professor who had provided the laboratory and the intellectual framework, but who had not, in Banting's view, earned the right to stand as a co-discoverer. Banting's friends and colleagues, among them several figures at the University of Toronto, who understood the political dimensions of the situation, spent considerable effort persuading him not to reject the prize outright. A refusal would have been unprecedented, scandalous, and ultimately self-defeating. Banting relented, but he accompanied his acceptance with a public gesture that was itself without precedent in the history of the Nobel Prizes. He announced that he would divide his share of the prize money equally with Charles Best. The message was unambiguous. Banting was using the most visible platform available to him to declare before the world that the Nobel Committee had made a mistake, that Best, not MacLeod, was the true co-discoverer of insulin. MacLeod, stung by the very public nature of the rebuke, responded with a symmetrical gesture. He announced that he would share his half of the prize money with James Collip. The four men were now arranged in two opposing pairs, Banting and Best on one side, MacLeod and Collip on the other, and the symmetry, far from resolving the conflict, only crystallized it. The scientific community, the press, and the public were invited to choose sides, and most of them did. The question at the heart of the dispute, who truly discovered insulin, was not a simple one, and the passage of a century has not made it simpler. The case for Banting rested on originality and initiative. He had conceived the experimental idea. He had pursued it at great personal cost, abandoning his medical practice, depleting his savings, and enduring months of grueling laboratory work in conditions that more established scientists would have found unacceptable. He had performed the surgeries that produced the first active extract. He had driven the project forward through sheer force of will at moments when it might easily have been abandoned. Without Banting, there would have been no experiment, no extract, no starting point for everything that followed. The case for Best rested on partnership and indispensability. He had performed the biochemical analyses without which the experimental results would have been meaningless. Numbers without measurement are not science. He had worked alongside Banting for every hour of that summer, sharing the labor, the setbacks, and the incremental triumphs. He had been, in every functional sense, a co-investigator rather than a mere assistant. The fact that he was a student, that he lacked a doctoral degree, that his name carried no institutional weight, these were matters of status, not of substance. His exclusion from the Nobel Prize felt, to many observers, like a punishment for being young. The case for MacLeod was more complex and, in certain respects, more difficult to communicate to a public that preferred clear narratives of heroic individual achievement. MacLeod had not conceived the original idea. He had not performed the surgeries. He had been absent during the pivotal summer months, but his contributions, viewed in their totality, were woven into the fabric of the discovery at every level. He had provided the institutional resources without which the experiments could not have taken place: the laboratory, the animals, the funding, the administrative support. He had shaped the experimental design with his detailed instructions before departing for Scotland. Upon his return, he had imposed the scientific rigor that transformed promising but methodologically flawed results into publishable, credible findings. He had redirected the extraction strategy toward fetal calf pancreas, dramatically improving efficiency. He had brought Collip into the project and supervised the expansion that led to clinical trials. He had presented the findings to the international scientific community with an authority and clarity that Banting, by his own admission, could not have matched. And he had contributed years of prior expertise in carbohydrate metabolism that provided the intellectual context within which the discovery made sense. The case for Collip, though he was not named as a laureate, was in some ways the most concrete of all. His purification of the extract was the single technical achievement that separated a failed first injection from a triumphant second one. Without Collip's work, insulin would have remained a crude, toxic laboratory substance, effective in dogs, dangerous in humans, and clinically useless. The 12 days between Leonard Thompson's first injection and his second, the interval during which Collip perfected his purification method, represented perhaps the most critical bridge in the entire chain of discovery. That he received no Nobel recognition at all, not even a share of the prize, was a judgment that many biochemists regarded as a serious injustice. The Nobel Committee's decision to honor Banting and MacLeod, while defensible on certain grounds, satisfied almost no one. It reflected the committee's institutional tendency to recognize a senior scientist who provided the research environment alongside the individual who generated the key experimental insight, a pattern visible in other Nobel awards of the era. But in this case, the pattern produced a result that felt, to many participants and observers, fundamentally wrong. Banting believed the prize should have gone to himself and Best. MacLeod believed his own contribution had been undervalued rather than overvalued. Best felt robbed. Collip, characteristically, said little in public but harbored his own sense of having been overlooked. The broader scientific community found itself divided along lines that often reflected national, institutional, and personal loyalties rather than dispassionate evaluation of the evidence. Canadian public opinion rallied overwhelmingly to Banting, who was already becoming a national hero, the small-town surgeon who had triumphed through determination and courage. MacLeod, perceived as the aloof Scottish professor who had swooped in to claim credit for work he had not performed, became an object of public resentment in Canada, despite his genuine and substantial contributions. In Britain and in parts of the European scientific establishment, the assessment was more favorable to MacLeod, whose rigorous methodology and deep expertise were better appreciated by those who understood how scientific research actually functioned. There was, beyond the four principles, another figure whose shadow fell across the priority dispute, though his claim was advanced primarily by others and only fully articulated in later decades. Nicolae Paulescu, the Romanian physiologist working in Bucharest, had published results in the spring and summer of 1921 describing a pancreatic extract he called pankrine, which he had shown to reduce sugar levels in diabetic dogs. His publications predated the first Banting and Best paper, and his experimental methods were, in several respects, more rigorous than their early work. Paulescu had been pursuing the internal secretion independently, unaware of the Toronto experiments, and he had obtained results that were genuinely significant. His exclusion from the Nobel Prize, indeed, his near-total absence from the canonical narrative of insulin's discovery, has been a subject of ongoing historical reassessment. The question of Paulescu, however, is complicated by factors beyond the purely scientific. His extract was never brought to clinical use in humans during the critical period. He lacked the institutional support, the industrial partnerships, and the biochemical purification expertise that the Toronto team assembled. And his later career was overshadowed by his association with extreme nationalist and anti-Semitic political movements in Romania, associations that have made his scientific rehabilitation a morally fraught endeavor, entangling questions of credit with questions of character in ways that resist easy resolution. What the insulin priority dispute revealed, beyond the specific grievances of its participants, was a structural problem in the way science recognizes achievement. The Nobel Prize, by its design, honors individuals at most 3 per category. It was created in an era when the model of scientific discovery was the lone genius working in isolation, a Darwin, a Pasteur, a Koch. But insulin was not the product of a lone genius. It was the product of a collaboration, fractious, unequal, and often bitter, but a collaboration nonetheless. 4 men contributed 4 distinct and essential elements: the idea, the measurement, the institutional framework, and the purification. Remove anyone, and the timeline of discovery shifts, perhaps by months, perhaps by years, perhaps in ways that would have cost thousands of additional lives. The Nobel system, designed to celebrate individual brilliance, was structurally incapable of honoring this collective reality, and its attempt to do so produced not clarity but lasting bitterness. The personal consequences were profound and permanent. Banting and MacLeod never reconciled. Their interactions after the Nobel announcement were minimal and strained, conducted through intermediaries when they occurred at all. The atmosphere within the University of Toronto's medical faculty became poisoned by factional loyalty. Colleagues were expected to align themselves with one side or the other, and many did, with consequences for careers and friendships that persisted for years. MacLeod, increasingly uncomfortable in Toronto, began to consider a return to Scotland. Collip, who had never sought the spotlight and who found the entire controversy distasteful, withdrew into his own research with a quietness that was part temperament and part self-preservation. Best, the youngest of the four, was left to navigate the early years of his career under the shadow of a perceived injustice. Honored by Banting's gesture, excluded by the Nobel Committee, and permanently marked by the sense that history had not treated him fairly. The fracture was complete. The four men who had collectively assembled one of the most important medical achievements of the 20th century would never again work together, never again speak of their shared accomplishment without bitterness, and never agree on the fundamental question of what had happened and who deserved the credit. The discovery itself, luminous, transformative, life-saving, would endure. The relationships it destroyed would not. And yet, even as the principles turned away from one another, the substance they had created was spreading outward across the world, reaching hospitals, clinics, and family homes on every continent, transforming a condition that had been a swift and merciless sentence into something that could be managed, endured, and survived. The human meaning of insulin, the children who gained years, the families who were spared the worst, existed entirely apart from the question of who deserved the Nobel Prize. It was larger than any of them. It belonged, as Banting himself had insisted, to the world. The years that followed the Nobel Prize carried the four men in different directions, as though the centrifugal force of their shared achievement had flung them apart along trajectories that none of them could have predicted and none would have chosen. The discovery that had bound them together became, paradoxically, the thing that defined their separateness, each man living out the remainder of his life in the long shadow of a single accomplishment, struggling in different ways to step beyond it or to make peace with what it had cost. Frederick Banting became, almost overnight, the most famous Canadian of his generation. The country embraced him with a fervor that went beyond scientific admiration. He was transformed into a national symbol, the small-town surgeon who had triumphed over the establishment, the war hero who had saved children, the modest man who had sold his patent for $1. The Canadian Parliament voted him a lifetime annuity of $7,500 per year. The University of Toronto created the Banting and Best Department of Medical Research and appointed him its first director. In 1934, King George V conferred upon him a knighthood. He was Sir Frederick Banting now, celebrated wherever he went, invited to lecture, to preside, to represent Canadian science on the world stage. And yet the man behind the honors was deeply uneasy. Banting had never been comfortable with attention, and the scale of the recognition he received after 1923 was something he was constitutionally unsuited to bear. He was not a natural public speaker. He distrusted journalists. He found the social obligations of fame, the dinners, the committees, the ceremonial appearances, exhausting and hollow. More troublingly, he struggled to find a second act worthy of the first. He threw himself into a series of research projects, cancer, silicosis, aviation medicine, with the same intensity he had brought to the insulin work, but none produced results of comparable significance. The restlessness that had driven him to MacLeod's door in 1920 now drove him from one laboratory to another, searching for a breakthrough that never came. There was something almost tragic in the pattern. A man who had achieved the extraordinary at 30, spending the next 2 decades trying to prove that it had not been an accident. His personal life reflected the same turbulence. His first marriage, to Marion Robertson, deteriorated under the pressures of fame and temperamental incompatibility, and ended in divorce in 1932, a painful and public dissolution that added to his sense of dislocation. He married again in 1937 to Henrietta Ball, and by the accounts of those close to him, the second marriage brought him a measure of happiness that had long eluded him. But the respite was brief. When the Second World War erupted, Banting volunteered immediately for military research, driven by the same sense of duty that had taken him to the trenches in 1916. He became involved in research on biological warfare, aviation medicine, and the physiological effects of high-altitude flight. In February of 1941, he boarded a Hudson bomber in Newfoundland, bound for England on a mission related to his wartime research. The aircraft developed engine trouble shortly after takeoff. It came down in the frozen wilderness of the Newfoundland interior. The pilot survived the impact. Banting sustained severe injuries in the crash, and despite initial efforts to hold on, did not survive the night. He was 49 years old. The man who had given the world one of its most important medicines was lost in a frozen landscape, far from any hospital, beyond the reach of any treatment. MacLeod's trajectory after the Nobel Prize was quieter, but no less marked by the consequences of the insulin dispute. His position at the University of Toronto, once a source of professional pride, became increasingly untenable. The Canadian public had largely sided with Banting in the credit controversy, and MacLeod found himself cast in a role he had never sought and could not escape, the outsider who had claimed credit for another man's work. The characterization was unfair, but fairness had little purchase in the court of popular opinion. Colleagues who had previously respected him grew cautious, unwilling to be seen as aligned against the national hero. The atmosphere in the department became strained, and MacLeod, proud and sensitive beneath his composed exterior, felt the chill acutely. In 1928, he accepted an offer to return to the University of Aberdeen as Regius Professor of Physiology, a prestigious appointment that was also, unmistakably, a retreat. Back in Scotland, he continued to publish, to teach, and to conduct research of genuine merit. But his health declined. He developed a progressive form of arthritis that gradually limited his mobility and his capacity for laboratory work. By the early 1930s, the disease had become severely debilitating. He passed in Aberdeen in March of 1935, at the age of 58, recognized by his peers as a distinguished physiologist, but remembered by the wider world primarily, and, he would have said, unjustly, as a footnote to Frederick Banting's story. Charles Best, the youngest of the four, faced a different kind of burden, the burden of the man who was almost recognized. Banting's public gesture of sharing his Nobel Prize money had ensured that Best's name was permanently linked to the discovery, but the absence of formal Nobel recognition left a wound that never fully closed. Best was acutely aware that history's judgment rested on institutional markers, prizes, titles, official records, and that Banting's personal generosity, however meaningful, could not substitute for the validation that the Nobel Committee had withheld. He channeled his frustration into a career of remarkable productivity. He succeeded MacLeod as head of the physiology department at the University of Toronto and built it into one of the leading research centers in North America. His subsequent scientific contributions were substantial. He played a key role in the development of heparin as an anticoagulant, conducted important research on choline and its role in preventing liver damage, and contributed to the understanding of histaminase. He received numerous honors from governments and scientific institutions around the world, virtually every form of recognition except the one that mattered most to him. He spent decades advocating, with varying degrees of directness, for a reassessment of his role in the insulin discovery, and he was not above shaping the historical record in ways that emphasized his contributions and minimized those of MacLeod and Collip. He passed in 1978 at the age of 79, laden with honors and still, in some fundamental sense, unsatisfied. Collip's path was perhaps the most graceful of the four, if also the least visible. He returned to the University of Alberta after his sabbatical year and resumed the quiet, methodical research career that suited his temperament. His subsequent achievements were impressive by any standard, most notably the isolation of parathyroid hormone, a discovery that in another context might have earned its own Nobel consideration. He later served as chair of biochemistry at McGill University, and then as dean of medicine at the University of Western Ontario. He published extensively, trained generations of students, and earned the deep respect of his peers in the biochemistry community. What he did not do, conspicuously and perhaps deliberately, was engage in the public debate over insulin credit. He rarely gave interviews about the discovery. He did not write memoirs or position papers defending his role. He allowed his subsequent work to speak for itself, and he seemed to find in that work a satisfaction that the insulin controversy, with all its noise and bitterness, could not provide. He passed in 1965, at the age of 72, mourned by colleagues who remembered him as a scientist of exceptional skill and a man of uncommon discretion. And what of the patients? The first generation of human beings whose lives were reshaped by the substance these four men had brought into the world. Leonard Thompson, the 14-year-old boy who had received that first uncertain injection in January of 1922, left Toronto General Hospital and returned to a life that insulin made possible but could not make easy. He lived for 13 more years, sustained by daily injections, navigating the complexities of a chronic condition that the medical profession was only beginning to understand how to manage. The long-term consequences of diabetes, damage to the vessels, the kidneys, the eyes, the peripheral nerves, were not prevented by insulin. They were postponed. Thompson developed complications over the years, and in the spring of 1935, at the age of 27, he succumbed to pneumonia complicated by the cumulative vascular damage that the disease had wrought despite years of treatment. His case illuminated a truth that the initial euphoria of the discovery had obscured. Insulin was not a cure. It was a reprieve. It transformed a swift and merciless condition into a chronic, manageable one, an extraordinary achievement, but not a final victory. This distinction between rescue and resolution defined the experience of the first insulin generation. Patients who had been weeks or months from the end were given years, sometimes decades, of additional life. But those years came with a daily discipline that was itself demanding. Multiple injections, careful dietary management, constant monitoring for signs of complications. The insulin available in the 1920s and 30s was crude by later standards, derived from the pancreases of cattle and pigs, variable in potency from batch to batch, capable of triggering allergic reactions in sensitive patients. Dosing was imprecise. The risk of administering too much causing a dangerous drop in sugar levels, with tremors, confusion, and loss of consciousness, was ever present. Patients and their families learned to navigate these hazards through experience, trial, and error, developing an intimate daily relationship with a substance that was simultaneously their lifeline and their burden. The broader transformation of diabetes care unfolded gradually through the 1920s and 30s. Specialized diabetes clinics emerged in hospitals across North America and Europe. Dietary counseling evolved from Allen's punishing starvation regime into more nuanced nutritional guidance that balanced caloric intake with insulin dosing. New formulations of insulin were developed, longer-acting preparations that reduced the number of daily injections, more standardized products that improved consistency. The Danish company Nordisk Insulin Laboratorium and the rival Novo Therapeutisk Laboratorium, both founded in the 1920s, became major producers, alongside Eli Lilly, establishing an international supply chain that made insulin available to patients in dozens of countries. The infrastructure of chronic disease management, a concept that barely existed before 1922, began to take shape around this single substance. Yet for all this progress, the fundamental nature of the disease remained unchanged. Insulin replaced what the body could not produce. It did not restore the body's ability to produce it. The islets of Langerhans, once destroyed by the autoimmune process that caused juvenile diabetes, did not regenerate. The patient remained dependent on external supply, one injection at a time, one day at a time, for the remainder of a life that insulin had extended but not freed from the shadow of the condition that made it necessary. The story of insulin, which had begun as a race against time and a triumph of scientific will, was revealing itself to be something longer, more complicated, and more ambiguous than any of its creators had imagined. Not an ending, but a beginning. Not a cure, but a covenant between a patient and a substance, renewed every day, with no final resolution in sight. In the small city of London, Ontario, on a residential street that looks much as it did a century ago, there stands a modest house that has been preserved as a museum. It is not a grand building. It has no columns, no sweeping facade, no architectural ambition. It is the kind of house a young doctor with a failing practice might rent, affordable, respectable, unremarkable. Inside, among the period furnishings and the carefully maintained exhibits, there is a room that has been restored to approximate the way it might have looked on an autumn evening in 1920. A desk, a lamp, a few books. And under glass, protected from the slow erosion of time and human touch, a small notebook lies open to a page of hurried handwriting. The 25 words, misspelled and syntactically rough, that Frederick Banting scribbled at 2 in the morning when an idea seized him and would not let go. The notebook is the relic at the center of a story that, depending on how one tells it, is about scientific genius, institutional collaboration, personal bitterness, moral idealism, or all of these at once. The 25 words it contains are not elegant. They do not read like the pronouncements of a visionary. They read like the notes of a tired man grasping at something just beyond his understanding, a surgical intuition, half-formed and imprecise, that happened to align with one of the deepest unmet needs in the history of medicine. That alignment was not inevitable. It was not destined. It was the product of a specific convergence, a particular article read on a particular night by a particular man whose combination of stubbornness, surgical skill, and professional desperation made him willing to pursue an idea that more cautious, more credentialed, more knowledgeable scientists might have set aside. The story that flowed from those 25 words has been told many times in many ways with many emphases. It has been told as the triumph of a lone outsider against an indifferent establishment. It has been told as a case study in the sociology of scientific collaboration. It has been told as a cautionary tale about the corrosive effects of ego and the structural inadequacy of prizes. Each of these tellings captures something real, and none captures everything. What remains, when the narrative layers are peeled away and the competing claims are set aside, is a fact so simple and so large that it resists embellishment. Before 1922, a diagnosis of juvenile diabetes was a sentence measured in months. After 1922, it was not. The children who had been wasting away on starvation diets, the hollow-eyed figures in the wards of Toronto and New York and London and 100 other cities, were given the possibility of growing up. Not all of them were saved. Not all who were saved lived long lives. The substance that rescued them was imperfect, demanding, and carried its own burdens. But the possibility itself, the simple, astonishing fact that a child diagnosed with diabetes could now expect to see adulthood, was a transformation so profound that it altered not only the practice of medicine, but the meaning of the disease itself. 4 men made this possible, and the tensions between them have become inseparable from the story of what they achieved. It is tempting, from the distance of a century, to adjudicate their dispute, to declare a winner, to assign percentages of credit, to determine once, and for all who deserved the Nobel Prize and who was unjustly excluded. But the honest conclusion, supported by the evidence and affirmed by the most careful historians of the discovery, is that no such adjudication is possible. The insulin story was not the work of a single mind. It was the product of four distinct and essential contributions that cannot be meaningfully ranked against one another. Banting's idea was the spark. Without it, the specific chain of events that led to insulin's isolation in 1921 would not have occurred, or would have occurred later elsewhere, under different circumstances, with consequences for the thousands of patients who were running out of time. Best's technical skill and unwavering partnership gave the idea its experimental foundation. Without his measurements, the results of that summer would have been anecdotal rather than scientific. MacLeod's institutional support, intellectual rigor, and strategic redirection provided the framework within which a promising but crude experiment became a credible, publishable, and expandable discovery. Collip's purification was the bridge between the laboratory and the bedside, the essential 12-day interval that separated a failed first injection from a triumphant second one. Remove any single element and the structure collapses, or at least deforms into something slower, less certain, and less complete. The inability of these four men to recognize this mutual dependence, to see that each of them was necessary and none sufficient, was the human tragedy embedded within the scientific triumph. Banting could not forgive MacLeod for receiving credit he believed was unearned. MacLeod could not forgive Banting for the public humiliation of the Nobel gesture. Best could not forgive the committee for overlooking him. Collip could not find a place in a narrative that had been reduced to a two-sided conflict. Each man carried his grievance forward through the remaining years of his life, and the grievances outlasted all of them, perpetuated by students, by biographers, by national pride, and by the endlessly renewable human appetite for stories with clear heroes and villains. But there is another element of the story that has endured alongside the bitterness, and it is this element that gives the narrative its moral center. On the 25th of April, 1923, three of the four men, Banting, Best, and Collip, signed documents assigning their patent rights for the manufacture of insulin to the University of Toronto. The price, recorded in the legal instruments with the same dry precision that characterized all such transactions, was $1 per person, $3 in total, for one of the most valuable medical discoveries in history. The decision was not made naively. Banting and his colleagues understood that insulin would become a commercial product, manufactured and sold by pharmaceutical companies for profit. They understood that Eli Lilly and other producers would earn substantial revenues from its sale. They were not opposed to this. They recognized that industrial production required investment, expertise, and infrastructure that only commercial enterprises could provide. What they opposed was the idea that the discoverers themselves should profit from the suffering of others, that a substance standing between a child and an early grave should enrich the men who had found it. The patent was assigned to the university not to prevent commercial manufacture, but to ensure quality control, to prevent the production of dangerous imitations, and to embody a principle that Banting felt with the force of a moral conviction. This belongs to everyone. The $1 patent has become, over the intervening century, a symbol whose meaning has grown more complex and more poignant with each passing decade. In the years immediately following the discovery, it represented an ideal, the belief that medical science existed to serve humanity, that its fruits should be shared as widely as possible, and that the personal ambitions of individual researchers were subordinate to the collective good. This ideal was not unique to Banting. It was shared in various forms by many of the leading medical scientists of the early 20th century. Jonas Salk, decades later, would express a similar philosophy when asked who owned the patent on his polio vaccine. The notion that life-saving medical knowledge was a public good, not a private commodity, ran deep in the culture of biomedical research during this period. Whether that ideal has survived intact into the present is a question that the insulin story itself illuminates with uncomfortable clarity. The original patent expired long ago. The animal-derived insulin that Banting, Best, MacLeod, and Collip developed has been largely replaced by synthetic human insulin and by analog formulations engineered through recombinant technology, products that are more effective, more consistent, and more precisely tailored to patient needs than anything available in 1922. These newer forms of insulin are the products of decades of additional research, substantial corporate investment, and complex manufacturing processes that bear little resemblance to Collip's laboratory precipitation technique. They are also, in many parts of the world, far more expensive than the substance they replaced. The gap between the $1 ideal and the economic realities of 21st century pharmaceutical production has become a source of profound public debate, a debate in which the names of Banting and Best are frequently invoked, not as historical figures, but as moral reference points. This narrative does not presume to resolve that debate. It belongs to the domains of policy, economics, and ethics, and its complexities extend far beyond the scope of a single historical account. But the fact that such a debate exists, that the tension between medical idealism and commercial reality remains unresolved a century after insulin's discovery, is itself a measure of the story's enduring significance. The question that Banting answered with such moral clarity in 1923, who should benefit from a life-saving discovery, has not been answered with equal clarity by the world that inherited his gift. What can be said, without entering the territory of contemporary judgment, is that the gesture itself retains its power. Three men, standing at the threshold of wealth and fame, chose to give away the most valuable thing they possessed. They did so not because they were saints, they were, as the full narrative makes clear, flawed, jealous, insecure, and capable of pettiness, but because, at the moment when it mattered most, they recognized something larger than their own ambitions. The $1 patent was not an act of naivety. It was an act of conscience, performed by imperfect men, in full awareness of what they were surrendering. The flame of hope, a ceremonial fire lit in London, Ontario in 1989 by Queen Elizabeth II, burns continuously outside the Banting House Museum. It was kindled with the stated intention that it would not be extinguished until a true cure for diabetes is found. Not a treatment, not a management strategy, but a cure that would render insulin itself unnecessary. More than 3 decades later, the flame still burns. The cure has not yet come. And every day, around the world, millions of people reach for a vial or a pen or a pump that delivers, into their bodies, a substance whose existence traces back to a small room on an upper floor of a medical building in Toronto, where 2 young men, one a surgeon with nothing to lose, the other a student who won a coin toss, spent a sweltering summer trying to extract a secret from a fragile organ. The story of insulin is not a story with a neat ending. It does not resolve into a single moral or a single lesson. It is a story about the distance between an idea and its realization, about the collaborative nature of discovery and the competitive nature of those who discover, about the gap between saving a life and curing a disease, and about the enduring question of what we owe one another when science places in our hands the power to rescue the condemned. It is a story about 4 men who could not get along and who, together, changed the world. And it begins, as it always has, with a lamp, a desk, a borrowed book, and a man who could not sleep, because somewhere in the back of his mind, in a place where surgical intuition met unarticulated compassion, he understood that the children in the wards were waiting, and that someone, however unlikely, however unprepared, had to try.